evening, everybody. Welcome to this international webinar, the 51st webinar of the Believers Church Medical College and Hospital. And today, our subject of interest is neurology, and we have a special speaker talking on the natural history of epilepsy. We have with us the Professor of Neurology of the Queen's Square Institute of Neurology, University College London, head of the Department of Clinical and Experimental Epilepsy, honorary consultant neurologist at the National Hospital for Neurology and Neurosurgery, Queen's Square, London, director for scientific research, Stichting Epilepsy Intelligence in Netherlands, Hempstead, the Netherlands, and medical director of the Chalfont Center for Epilepsy, Chalfont St. Peter, England, UK. Distinguished faculty, Dr. Professor Josimir W. Sander, lovingly known as Lay Sander. Sir, welcome to this international webinar.
Thank you very much for the introduction.
With 200 publications, 90 plus editorials and commentaries, 10 commission reports, and being a peer reviewer for grant-giving bodies like the British Epilepsy Association and the member of prestigious associations like the American Epilepsy Society and Association of British Neurologists. Sir hails from Brazil, where he did his undergraduation and post-graduation and went on to train in the UK, complete his PhD, MRCP, FRCP, and also his FEAN. It's a great privilege, sir, to have you as our invited speaker. We welcome you again.
Thank you very much.
And to moderate this session, we have our own gem, Professor and Head of Neurology at the Believers Church Medical College and Hospital. Sir needs no introduction. Professor Dr. John K. John, sir. Sir trained extensively in neurology in the UK and elsewhere, and currently is the Head of Neurology at Believers Church Medical College Hospital. Extremely interested in research, patient care, and clinical neurology. Sir has been at the forefront of the neurology department at Believers Church Medical College Hospital and been driving force for the entire department. Sir, it's a great privilege to have you with us to moderate this session. Welcome, dear sir. Over to you to take over the session and hand over to the speaker. Over to you, John K. John, sir.
Thank you, Dr. Jacob, for the kind words. It's a pleasure to be with Dr. Lay Sander in the evening today. Yesterday was the World Epilepsy Day, and it is estimated that around 50 to 60 million people suffer from epilepsy. So that means epilepsy is one of the common neurological disorders. One thing unique about epilepsy is the social stigma associated with epilepsy. So whenever we make a diagnosis of epilepsy in a patient, the patient and the family are under tremendous psychosocial, psychological pressure. The treating doctor will have to answer a lot of questions. One of the most important questions they ask is, doctor, how long I have to take the medicine? Can I stop it after a few months or years? And we know that epilepsy is not a single disease. It's actually a symptom. And the natural history depends on the pathophysiological mechanism affecting the central nervous system, resulting in the epilepsy. So knowledge about that particular epileptic syndrome, the pathophysiological mechanisms, and the natural history is so important in taking the decisions and answering the queries. Now, today we have a very experienced person who has done a lot of research in this field of epilepsy, who has contributed tremendously to the scientific world, Professor Lay Sander. I'm so delighted and excited to listen to Dr. Lay Sander. So, Professor Sander, I invite you for the talk.
Thank you very much for your very nice welcome. Very nice and honored to be talking to you today. Of course, as I was speaking earlier with Dr. Jacob, it would be much nicer if I could be one of these days in Kerala, but at this point we will do it by Zoom. So I'm being asked to give you a talk and discuss aspects of the natural history of epilepsy, and I will try to do it in the next sort of 30 minutes. Some views on this issue. So I think it's very important that, as you already said, epilepsy is a symptom. And this is a big problem when you try to ascertain the natural history, because it depends on what epilepsy type we're talking. So epilepsy is not a disease on its own right, but it's just the tendency to have unprovoked seizures, which is a result of an underlying problem of the brain. And this is part of the complexity of trying to ascertain, to find out the natural history of a symptom complex. And I will come back to this. If we were to look at the difficulties, we already identified, quite important, is that it's a symptom. But it's a chronic condition for many people. It's a chronic disorder, and it has many patterns. Someone could have a remitting and relapsing pattern. Someone can have a continuous pattern of seizures over time. And it comes with a spectrum of severity. It does have very high somatic and psychiatric comorbidity, psychosocial comorbidity, and it will end up either in remission, and sometimes we can discuss with the patient, to come off drugs, as Professor John has asked, put this situation. But epilepsy, for people, particularly in the chronic condition, they may require medication in the long term, sometimes for a life prospect. So if no remission, seizures will continue and people will die. This is the story of our life. However, in epilepsy, death is often premature, and it's the most devastating aspect of this condition. It is not a benign condition. So we have many methodological problems in trying to ascertain the natural history. When we are trying to do this, we need to identify our cases, and epilepsy is full of problems with diagnosis. You may miss cases, and you may have cases that are being diagnosed as epilepsy that don't have epilepsy. So we have false negatives and false positives. We do not have a clear gold standard. And as most of the time, epilepsy is not there. And it is only the casual observation or the happenstance of an observation of a seizure or a video or something will provide the evidence of the diagnosis. We have definitions and classifications that keep changing, and people sometimes cannot keep up with this. People with epilepsy, because of the social stigma associated with it, they may conceal it, and this is maybe a big problem if you're trying to ascertain natural history. We have all sorts of selection bias and populations. But this should not be a surprise, because the tendency to have unprovoked seizures is caused by an underlying problem. It is not the epilepsy. So it's a symptom complex, another disease, and this needs to be always kept in mind. So if we looked at risk factors, and I think it's correct to say we should have risk factors rather than causes. Most of the time when we talk about the causes of epilepsy, we're actually talking about risk factors. And this will vary with age, family history, and where people come from. People that develop epilepsy early in life, childhood, adolescence, they normally will have something that is either developmental or a genetic condition. People having cognitive disorders or cerebrovascular disease, they're at high risk of developing seizures. So this is common in the sort of older age. But of course, a number of other risk factors for epilepsy, like traumatic brain injury, like infections of the central nervous system, and tumors may happen at any age. And as I said earlier, geographic location may help to see if we know the risk factor or find out a risk factor for a person. And this is, for instance, if someone comes from an endemic area for malaria or neuropsychosis or onchocerciasis. But of interest is that a family history of epilepsy seems to be a risk enhancer. And this already brings us this the constatation that there's always a genetic contribution to seizure risk. Now, I mentioned this right at the beginning, that epilepsy has a very high rate of comorbidities. And these are very important for us to understand. They are an important part of the burden that epilepsy poses on the individual and on society. They will affect the quality of life of the person. It will increase the utilization of health service, therefore increasing the financial. They may have a role in premature mortality, and they may complicate management. And it's very interesting to see that the comorbidity seems to be independent of seizure activity. So even if someone has epilepsy well controlled of medication, the comorbidity can still be a problem. So this is a very important lesson we have. And I always tell my residents and students that the second mantra in epilepsy, the first one being, is it epilepsy? The second mantra is epilepsy and what else? Because having epilepsy should increase the suspicion that other conditions may be present. So in terms of mechanism of association, why is epilepsy? Well, we could have something that is just a chance. Someone has a common comorbidity and epilepsy is common, so they could happen just by coincidence. But there could be some causative mechanisms, like someone has a head injury that can then cause a paralysis on one side and epilepsy. We could have a comorbidity that will lead to something else, which may lead to epilepsy. For instance, some of the autoimmune disease, they may increase the risk of vasculitis or inflammation in the brain, and this could lead to epilepsy. We could have what is called the indirect causal association or resultant mechanism. And this is when someone, for instance, takes a drug that will impose challenges to bone density, and then they have a pathological fracture. This would be a resultant comorbidity. But the most important is that when we have shared risk factors, either environmental or genetic, and sometimes they play, there is interplay between these two, genetic and environmental, and they can lead to epilepsy or a comorbidity, and they may be bidirectional. And this is very important in terms of trying to understand. Many of the comorbidities we see, they seem to have a bidirectional risk with epilepsy. For instance, if someone has a clinical significant episode of depression, over the next 3 years, this person will be at increased risk of developing epilepsy. And if you have epilepsy, you're going to be at a much higher risk of developing depression than the general population. This is something that we need to remember. And I think it's very important that we also take into account the genetics. The genetics play an important role in life. It's our blueprint. So there might be a genetic cause for the epilepsy. There might be a shared risk factor from a genetic factor, like a condition that can cause 2 or 3 comorbid conditions, one of them being epilepsy. And the genetic factor may bring on a comorbidity, which may play a role in the development of epilepsy. So the genetics do not rule it out. On the contrary, make them are part of the explanation. Now, before we move on, it's very important that we sort of look into what is nowadays called the social determinants of disease, in this case of a symptom. And epilepsy is clearly a disease of people that are poorer. We have consistently in higher income countries incidence around 50 per 100,000 around that number, whilst in resource-poor countries is much higher, and figures that are as high as 190, 200 per 100,000 have been reported, but it's usually over 80. So we clearly can see that epilepsy is more likely to happen in poor areas. And the possible reasons for this could be a number of things. They could be methodological. If we contaminate our sample with acute symptomatic seizures that have not been recognized as such, and in the absence of a sophisticated medical system, we may have problems with the case ascertainment methods, and we're picking up what is not epilepsy. But it's unlikely, because many studies from different, with using different methodologies, they all point to this. So it's consistent. And as I said earlier, there might be the social determinants of health, trauma, brain trauma during or after birth. And we know that in some areas, brain trauma are more common than others. The presence of infections of the brain, social factors, and there might be genetic factors also involved here. So, but this is not just a problem in low-income countries, because it's also evident showing that if you are in a high-income country, or in the old times called developed economies, you will see that people that are in the sort of lower strata in society are much higher risk of developing epilepsy than those that are in the sort of more wealthy elements or strata of society. So the evidence is clear in poor settings and also in high income economies that epilepsy is a condition of the poor. And this brings in the issue which is called the epidemiological paradox. And this epidemiological paradox is basically the discrepancy between the prevalence of active epilepsy and the higher incidence. So consistently, if we look at the prevalence, it's going to be somewhere between 4 and 10 per 1,000. But if we were to look at some of the incidence numbers that have been reported, and epilepsy is not a condition that would get better, we would expect much higher prevalence. But the numbers seem to be similar everywhere. And what is this telling us? And this is what they so-called epidemiological paradox. Now, we know that there is a massive treatment gap. Many people in many parts of the developing world, the low-income countries, they do not receive antiepileptic drugs. Actually, worldwide, there's only antiepileptic drugs produced to be able to treat, using conservative estimates of prevalence, about 30% of people. So we know from that most people with epilepsy are not treated. And I think it's fair to say that they are consistent but sort of circumstantial evidence coming forward that spontaneous remission play a role. And this is people that probably will get better regardless of drugs. And of course, the role of premature mortality. And there is coming stronger and stronger circumstantial evidence, regardless of where it's coming, be it a wealthy country or a poorer country. It looks like that people with epilepsy are likely to die earlier and prematurely. And I have already mentioned this, that epilepsy is not really a benign condition. There is consistent and overwhelming evidence of this increased risk of premature mortality. It is greatest in the young and in those with chronic epilepsy, and seems to be greater in resource-poor settings. But I think there is no doubt that we might be under-recording death from epilepsy or in epilepsy in higher income countries. Usually rely on their certificates. So, but if we follow cohorts, we will see that this is really an issue where standardized mortality ratios, how we measure premature mortality, is much higher in rural areas of a number of poor settings, for instance, in rural China, in Georgia, in the former Soviet Union, and in Kenya. So this is just to show you, these are two graphs from two different studies in China. This is actually from West China, from Sichuan province, where we can see if you have an SMR of 2, that means you're two times more likely to die earlier than your peers in the community. But we can see here that people under the age, let's say people under the age of 50, they have standardized mortality ratios as high as 40. And this has been also replicated in a much bigger study in 5 provinces of China. It's now, please notice that this is a logarithm scale, and it shows that people have a staggering high mortality. And this is why then you can see why the paradox is there, but also it shows that epilepsy takes 20, 30 years of the life expectancy of a person that has it. So what is the major problem for this premature mortality, premature death? Of course, epilepsy plays a role in the form of status epilepticus and what's called SUDEP, sudden unexpected death in epilepsy. There is an increase in accidents. For instance, in part of China, where there are paddy fields, the number of drowning amongst peasants that have epilepsy is shockingly high. And the standardized mortality rate for drowning in Sichuan province seems to be in excess of 80. So this is a result of accidents. But there is also good evidence that the comorbidity, be it somatic or psychiatric, also plays a role. And you can see that some of the diseases that are seen, or some of the comorbid conditions seen with epilepsy, they are associated with higher mortality. So there is no doubt that comorbidity plays an important role in this premature mortality. And it's very interesting that even when people are seizure-free, they may have had epilepsy, they become seizure-free, they may come off drugs, but they still will carry an increased risk of premature mortality. And this is one cohort followed up for nowadays almost 30 years. And it shows that premature mortality persisted despite most people becoming seizure-free. And this is telling us something. The premature mortality seemed to be independent of seizure activity. And this again enforces the role of the comorbidities as the player, as the driver for this increase in premature mortality. This is a study that looked at an incident cohort, the one that I mentioned, and was looking at the different causes or immediate cause or the underlying cause. And as you can see, epilepsy or epilepsy-related death were a very small number, and the majority died of comorbidities. And this is a very important message, that comorbidity is such an important part of the burden associated with epilepsy. So moving on now to a further part to understand what we have is the role of treatment. First, we need to look at the treatment paradigm, which, despite all what is said, the paradigm is still empirical rather than rational. It is symptomatic. We control or treat the seizures, but we do not control or treat the epileptogenic process. And indeed, we do not have curative or disease-modifying treatment in epilepsy. We use a drug for this person to see if this will control the seizures, and if it doesn't work, we move to another one. This brings in a number of problems. One is that it's empirical, shooting in the dark and hope it works. But the second one, it actually brings in decreasing returns. An analogy would be if you would to treat blindly anemia. Quite a number of people would get better with iron sulfate, probably 50%. But that's not resolving the problem for many. If they have worms, if they have an overload of worms, or if they have a bleeding point, So we need to sort of try and see it like that. So you're treating a symptom, and regardless of the drug we use, about 50% of people get better with the first drug. That's telling us something. So if the people do not respond to the first drug and we try a second, a quarter of people will become better. But after this, it's a law of decreasing returns. And if you have to try the fourth drug, fifth drug, less than 5% of people will get better. And this is something that can be very frustrating for the doctor, but also and particularly for the patients and their families, because they're saying, okay, we do it. It's like a trial and error. And we need to be very upfront about the fact that we use an empirical paradigm of treatment. So what can we say? Well, we can say overall that's probably, and this is really consistently reported, that up to a third of people, they are refractory to the current anti-seizure medications. And they have what's called chronic or drug-resistant epilepsy. And we have some markers that will say that someone is more likely to have chronic or drug-resistant epilepsy. If they have an early onset of their seizures, if they have focal seizures, more than one seizure type, if the history from onset to where they are is over 2 years, regardless of the number of drugs, these are markers for drug-resistant epilepsy, the presence of structural lesions. So if someone comes to this, one of these markers, we can actually prognosticate that things will be a little bit hard to treat, but we should not be nihilistic and not treat, because depending on how many drugs we have used, we still can make a difference. Now, how do we define chronic epilepsy? I think that there's all sorts of definitions. International League Against Epilepsy definition is people have failed 2 first-line anti-seizure medication, they would get a label drug-resistant. There are some pragmatic reasons for this. Someone that has epilepsy that is active 2 years after onset are very likely to have chronic epilepsy, and people that have a great number of seizures in the early stages of their condition. But I think it's very important that we remember that there's quite a lot of pseudochronicity out there. And this includes people that have a misdiagnosis of epilepsy that's consistently between 15 and 20% in high-income countries, tertiary level clinics, where we see a number of people that don't have epilepsy. People might be receiving the wrong drug for their epileptic syndrome. For instance, someone that has juvenile myoclonic epilepsy, been treated with a sodium channel blocker, or someone that has a focal seizure mimicking a generalized seizure, they're never exposed to sodium channel drugs. So we need to remember this. But the most important reason for pseudochronicity is people not taking the treatment. And this is the lack of adherence, lack of compliance is a big issue. And it's often underplayed or underscored by doctors. And we need to be very, very clear that we need to understand if people are really taking the tablets. If someone hasn't had a seizure for a while, and the only reminding they have of the problem is taking the tablets, you can see that often taking the adherence may fail. And that's the commonest reason, in my experience, for pseudochronicity. People don't like to admit to the doctor that they have not taken the tablet. Now, of interest is that this incident study that I mentioned has shown that the remission might be better than it's often said. And indeed, maybe as many as 80% rather than 60 to 70% will become seizure-free with the current medications. There doesn't seem to be a difference between people that have their epilepsy started in childhood or in adult life. But the big issue is that quite a lot of people die. And indeed, in this cohort of almost 800 people, 37% had died. And that was a risk of premature death twice that you would expect in this population. So this is really something that we need to remember. If people have epilepsy, they're at high risk of dying. But if they don't die, they survive, then there's a good chance they could become seizure-free, provided that medications are used appropriately. Now, I already mentioned that there might be changes in this number of people with intractable epilepsy from 65 to 70, going up to 80, and there's some more evidence coming that the number is higher. But what is actually causing this? Are we better in doing something? Are we better in spotting and managing pseudochronicity? We could be. Is prognosis for seizure control better, or has the natural history changed? And I will tell you one situation where we clearly seem to have seen a change in natural history, although I'm the first to say that other reasons may also be part. And this is the declining numbers that is seen in developing countries of hippocampal sclerosis. And this is a clear trend that has been seen in many places where you know, if we look back 20 years and we look now, there's been quite a dramatic fall in the number of cases coming up with this hippocampal sclerosis. The reason for this is that we are very aware of this is because of epilepsy surgery, because this is a condition that has a very good outcome when operated. Now, why is this declining numbers of hippocampal sclerosis? Is there a changing in the natural history? Maybe it's following demographic trends, and I will come back to this. We might be better at managing brain infections and febrile seizures, which seems to be often associated with the sclerotic hippocampus. Or do we have now better treatment? We don't really know. We might never know. What we know is that there's been a very dramatic demographic shift in epilepsy in the last 4 decades. This is clearly seen in high-income countries. You see a significant increase in the incidence in the elderly. You see a slight increase in the first year of life. Then there is a decrease in childhood epilepsy. The total number of cases has not changed, but the proportions have. So you have a bimodal distribution of incidence in the first year of life and people over the age of 60. So it's bimodal. Now, the reasons are unclear, but they coincide with expectant mothers adopting healthier lifestyles coming on the aftermath of the thalidomide scandal. There might be improvements in pre and perinatal care. As already mentioned, there might be better improvements in the management of febrile seizures. There might be a role for immunization programs. And of course, in the elderly, increased life expectancy may play a role, although the commonest cause in the elderly is cerebrovascular disease. And we all know that the incidence of stroke has come down. The problem is that the strokes have come down, but we have cerebrovascular disease that are much less severe, causing epilepsy rather than paralysis. So this is a part of the explanation, but we might never know. So as I said, the reasons are speculative and we might never find out the causes. But I would say that in the elderly, cerebrovascular disease have played a role. And if I had to guess in childhood, I would say that probably there are fewer malformation of cortical development as a result of mothers being good, not exposing themselves to some situations during pregnancy, and maybe with improvement in prenatal and perinatal care, we have less birth hypoxia and trauma, but we might never find out what is actually going on. And I mentioned that antiepileptic drugs don't seem to make a big difference, and every drug that we come after the fourth drug seem to improve the life of 4 or 5% of people at the most. But with the increase of number of drugs, it might well be that a modest improvement with each drug, when they taken together, we see a higher number of people benefiting. And this could be how newer drugs could be playing a role. It's not an individual drug, but it's a combination of the different new drugs. So what next? Where are we, and where are we going from here? I think it's very important that neurology is moving away from disease, and medicine is moving away from disease models, and we are going into a more system approach. And there will be a major paradigm change in the next 10 years, which will be resulting from the genomic revolution. And as I already mentioned, it's very likely that seizures always have a genetic contribution. And I think it's very important that we remember that genetic does not mean always inherited. So these clusters of comorbidities that we see are likely telling us something. Epilepsy is likely to be a system problem, part of a spectrum, and it might not just be affecting the brain. And this is the message that comes with looking at the comorbidities. For instance, people that have generalized epilepsy at a higher risk of having diabetes type 1, and this risk seems to be bidirectional. This is telling us something which we have not yet worked out. Now, should this be a surprise? I don't think so. I think that it's very clearly, the genetic blueprints play a major role in our life, because life is a genetic disease, sexually transmitted, with 100% fatality. So this very simple consideration statement is telling us a lot about where we're going, and this will come more with this genomic revolution coming. So in 10 years from now, it's very likely that the neurology will be away from disease focus into a system approach. And we will be looking at disease of the developing brain, conditions of the maturing brain, the quiescent brain, and I'm afraid most part of our life, our brain is degenerating. So instead of you having Parkinson, Alzheimer as individual disease, these will be part of the spectrum of conditions of the degenerating brain. There will be a number of, let's put it, illness spectrum, where, for instance, we have a degenerative spectrum, we might have an immune inflammatory, and these interacting, the age of the brain, the spectrum that people comes in, and the genome will determine the sort of disorder someone has. And indeed, I think it's that the interactions about these four matrices will determine how someone will present their neurological problems. So we need to keep that in mind, because this is where we're moving, and we're seeing this coming more and more. So I mentioned earlier that epilepsy is likely to be, the symptom is likely to be part of a spectrum of conditions. Conditions that are mainly transient. This is something that comes and goes. For instance, migraine is highly comorbid with epilepsy. Bidirectional, so is depression, so is generalized anxiety disorders. We have sleep disorders. And these are all telling us something. And they might well be this functional spectrum, transient brain conditions. And there is data, for instance, nowadays coming forward that this change of a switch in an animal model of epilepsy in a rodent can either cause spreading depression, as seen in migraine, or an epileptic discharge. So these are coming together to show that there might be indeed commonalities which would explain this bidirectional risk. There are now systemic autoimmune disorders that are coming forward to fit into this, and this is also telling us something. For instance, we see this increase in cerebrovascular disease. I already mentioned diabetes type 1 and genetic epilepsies. The evidence now is coming forward of diabetes type 2 and focal epilepsy. So these constellations, these clusters of comorbidities are going to be very important in the way we look at disease in the future, and they should be nowadays systematically taken into our stratifications, and we should be always recording. As at the moment, we have a very disjoint approach. Are you coming to the neurology clinic because of your seizures? How are your seizures? oh, you have a gastric problem. Sorry, gastroenterology is in another hospital or another building. So we need to start having a more holistic approach to the problem. So the takeaway message here is that overall, someone that develops epilepsy will have a good prognosis. And most people may come off drugs. Probably over 70%, maybe as high as 80%, they will go into terminal remission if they're not dead. So we need to really keep this in mind, that epilepsy is not really a benign condition, but is actually a highly malignant condition that takes many years of someone's life expectancy. The prognosis is largely dependent on the stage of brain development and the background etiology, genetic or otherwise. This is very clear. If someone starts epilepsy during the brain maturation, the outcome is usually very good. While if someone starts epilepsy during the developing brain, the outcomes are not so good. And if someone has epilepsy arising from the degenerating brain, they will have a very good prognosis in terms of seizure control, but not so good for life. So this is my takeaway message. I hope I gave you sort of some views on how the natural history of epilepsy will look and how we will use this to understand better the brain. Thank you very much for listening.
Thank you, Professor Santer. It was a wonderful talk. Thank you very much. I'm sure our students and all the listeners have benefited a lot. So if there are any questions, I think we have some 15 to 20 minutes to take up some questions. You can in the chat box. Meanwhile, I will start off with some questions. Dr. Sander, you mentioned about the misdiagnosis of epilepsy, which is a problem, even in the best centers where we have a lot of facilities. Do you think we can minimize the misdiagnosis by using prolonged EEG rather than a short EEG most of the time?
I think that I am not a fan of short EEGs. Because, if an EEG is a window in someone's brain, into someone's brain, 20 to 30 minutes is unlikely to show much. So I tend, if I'm going to expose a patient to an EEG, I tend to do it more prolonged. And if ideally an overnight EEG is very helpful, because a lot of changes you see is in the sort of transition of sleep to wakefulness and vice versa. So I think that long EEGs are helpful, but EEGs need to always be taken into the clinical history and the context of clinical history. But there is a very good tool nowadays to diagnose epilepsy, and almost everyone carries it. And that is the mobile phone with a camera. So if you ask the relatives, the carers, someone to try and get a few clips of seizures and showing them in clinic, seeing them in clinic, reviewing them, sometimes might have better results than the EEG. But if you have the EEG and the camera, then it's even better.
Thank you. Another question. Dr. Santo, you mentioned about the mortality associated with the seizures, epilepsy, and especially in the young. Are there any specific biomarkers which are going to help to predict mortality?
Yeah, that's a very important question. I think that there are three drivers for this. One is a major is psychiatric comorbidity. And we know that people with epilepsy are more likely to have psychiatric problems. And epilepsy plus psychiatric problems, that is a clear marker for an increased risk of suicide, accidental death, people putting themselves in danger. Then we have this issue of the somatic comorbidities. Someone has diabetes, is not well controlled and can cause problems. And then in the third marker is convulsions. If someone has convulsions, they are at risk of going into status epilepticus, but they're also into risk of having what's called SUDEP, the sudden unexpected death. And if you ask me what's the most stronger predictor that someone could die of SUDEP, is having nocturnal convulsions. So, and there are studies already showing that sleeping alone is a risk factor for SUDEP. But I cannot prescribe sleep with someone for someone with epilepsy. But this could be part of the counseling you need to, you need to have with the patient. People might not like the idea of having someone in the room. I'm not saying, but this is something that make a difference. We don't clearly understand why, but sleeping with someone in the same room seems to be a protective factor.
Thank you, Dr. Sander. And is there any evidence that any specific anti-epileptic drug is superior in preventing or inducing remission in seizure control rather than seizure control alone?
No, I think that this is the problem you have when you have a empirical approach to treatment. It looks like that regardless of which drug you use, 50% of people get better with the first drug if they tolerate it. I wonder how many of them would get better if we were to use a good Kerala tea. Because, we might be treating those people that go into spontaneous remission. However, I think that even when you have a benign syndrome, benign Rolandic epilepsy, you're still at risk of morbidity resulting of the seizures. So you might have a benign syndrome, but you might die in SUDEP, because people with benign Rolandic epilepsy often have nocturnal seizures. So I think that you might be treating someone not so much for changing the prognosis, but to avoid morbidity and even mortality. Now, there are some drugs that we can say the other way. There are some types of epilepsy that we should avoid some classes of drug. And because they could act as a seizure, the seizures can get worse. So for instance, someone has a idiopathic generalized epilepsy. Good example would be juvenile myoclonic epilepsy. And 80% of people that have this, they will have a worsening of the condition if you expose them to a sodium channel blocker. So, you would avoid this to avoid harm, to avoid more seizures. But the other way around doesn't work as well as that. But with the development in genetics and, hopefully going towards personalized treatment, maybe in 5-10 years time, we will have drugs that we could indicate for someone at the early stages.
Thank you, Dr. Sander. There's one more question. Is there any role for anti-epileptic drug in strokes, cerebrovascular accidents? Because in prophylactic AED, anti-epileptic drugs, since stroke is one of the most common causes for seizures in the elderly.
Yeah, I think that that's a very important issue. At the moment, we don't have any evidence that prophylactic use of drugs will make a difference. But one good thing is that if someone has epilepsy as a result of stroke, they usually have a very good outcome with drugs. And actually, I heard this many times, even a sniff of a drug will do good. So I don't think that it's indicated prolonged prophylactic treatment. Of course, in the acute situation, you might use a drug, but it's always better to then take them off the drug and see what happens. Most of the time, people that have a stroke, they will have focal seizures. So there is a less risk in terms of SUDEP there. But I think it's always better to wait for the event to happen before you engage in the treatment. That applies as well for head injury. You may use a drug on the acute phase, but it's better to withdraw the chronic use of medication.
So I think there are no more questions. Thank you very much, Dr. Sander. It was a wonderful talk and we thoroughly enjoyed it, and it was all knowledge for us. Thank you very much for sparing your time, and over to Dr. Jacobs for winding up the session for the concluding remarks.
Thank you.
Thank you. Thank you very much.
That was truly an amazing session, Professor Sando. Thank you so much for that eye opener of a session. And I'm very much sure that all of our students and our junior doctors and rest of the participants from across the country would have really enjoyed and learned a lot from this session. And you've taken your time off your extremely busy schedule, and you've come over to share your beautiful session with us. We are extremely grateful, sir. Thank you so much.
Thank you.
And looking forward to hosting you in Kerala as soon as the pandemic wanes, and we will be having you with us in our institution. I mean, we'll take you to the backwaters with a fresh catch, and we are going to really have a good time. And of course, good CMEs for our children also to directly listen from you.
Many thanks, and I'm looking forward to it. Yeah. Bye-bye.
Thank you so much, sir. And John, sir, extremely grateful to you too, sir, for taking your precious time off and moderating this session. Thank you so much, sir.
Thank you, thank you so much. Thank you.
And special thanks to all our students and rest of the participants. I see a few of our senior faculty being here in the participant list. Sirs and madams, thank you so much for joining in. And it's been truly a wonderful journey. Of all our webinars, it's been 51 webinars now, and we have really made good progress in terms of disseminating quality lectures for students across the nation. And I look forward to good support from great faculty like Professor Lay, so that we can continue on and benefit more and more students across the length and breadth of this country. Thank you so much. With that note, stay safe, wear your masks, keep social distancing, wash your hands, and take care. Signing off from Believers Church Medical College and Hospital, Dr. Jacob. Thank you so much.